Thank you so much for leading us into that. My portion of this is going to be a little bit less comprehensive, if only because breast planning really is something of an art form. It's really hard to come up with slides and recommendations that are going to work for every patient. So we're going to look at some sort of high-level techniques and general guidelines to follow, but always the plan is going to have to suit the need of the patient and the clinical goal we're going for. So Kate just spoke very eloquently about treating patients using breast cancer patients, and we're going to talk a little bit about these plans. Generally, for treating breast, we treat using tangents, as we call them. We'll have a medial tangent and a lateral tangent, whose goal is to isolate the ipsilateral breast from the rest of the anatomy. We're going to take a look more at that soon. I've provided here some general guidelines for constructing the field, and we'll take a look at some of those. So a useful tool is to place wires on the patient at the time of simulation. Some of these borders are going to describe the palpable breast, which is, to the trained eye, you can make a good estimation about where that's going to be on the CT. But when you're in the room, if you place that radio opaque marker at the top and bottom, even the medial and the lateral sides, you'll give yourself more tools to design the 3D plan later. Reviewing a skin rendering like this is always advisable, because you'll be able to see very clearly what it's going to look like when the patient is on the table. So our medial border here is going to be right along the midline of the patient as often as possible, being careful not to cross over midline as often as we can. As Kate described, one of the risks of treating patients is secondary malignancy later in life, and that contralateral breast is particularly susceptible to that. So we're going to try to isolate and spare the contralateral breast. The inferior border is about 2 centimeters beneath the inframammary fold, and you can see it's aligning quite well to that wire we placed on the patient. The superior border is a little trickier to see, but we're going to use the combination of our wire, the palpable breast tissue that we can see, and we'll also see on the 3-dimensional images in a moment how that ends up looking. For the purposes of treating just the breast by itself, we recommend that the isocenter be placed kind of evenly, about at the plane of the nipple, so that the divergence in the superior and in the inferior directions is about even. That gives us pretty decent geometry. And the last margin that I talked about is this idea of flash beyond the external contour. So this field that you're seeing is called a DRR. This is our digitally reconstructed radiograph, showing that same field that I was just displaying from the point of view of the field. So here we have our isocenter here at the plane of the nipple, creating an even divergence superiorly and inferiorly. The superior and inferior jaws are matched to those wires, which we placed to be at the palpable breast tissue. And we have our collimator turned slightly to follow the angle of the chest wall. This allows us to minimize the blocking that we need to do using our MLCs here in order to create that really nice flat match line that we're going after. All these little jagged lines here, that is the MLC blocking, which is being produced by the following of this midline wire structure, which I have turned on here. The last aspect to discuss is this flash. We have our field open about 2 centimeters beyond where the patient's anatomy ends, partially to increase the robustness of the plan. If the patient experiences any swelling during treatment, if the setup is a little bit imperfect, if there's any rolling on the table, we really want to make sure that so long as we're following the midline contour quite well, we don't have as much to worry about over here. The breast is going to be treated inside of this field. 2 cms of lung inside the field is a good starting place. Different doctors and different people will have a different tolerance for exactly how much lung ought to be in the field, but that's usually a good rule of thumb in order to make sure that the entire ipsilateral breast is covered while we're continuing to spare the contralateral breast. So let's move on. Once you've created those fields and calculated your dose, this is what your dose distribution might look like. And one thing you may note, we have our isodose lines on in here. I'll invite you to look at the key later to see what these all represent, but our 100% isodose line is in yellow, And these lines that are inside of this are the hot spot of the plan. As you might expect, the separation across these two tangential fields changes quite a bit over the course of the breast. Here we're treating through a much deeper part of the tissue than that same plane is treating here closer to the nipple. So very typically when you're treating breast using tangents, you're going to have hot spots which are closer to the nipple and a little more anterior, and your cold spot is going to tend to be along the chest wall. We want to try to keep the dose as close to that chest wall as we can, but we also don't want to introduce this much hot spot into the field. It's especially your hotspot is going to be a bit worse when you're using low energies. This is a 6 MV field, and it could be made better by using a higher energy, something like 10x, 15x, or beyond. But we really don't, unless otherwise directed by the physician, we tend to try to treat as much of the skin as we can. We don't want to introduce that skin sparing unless it's appropriate to do that. So we always try to plan with that lower energy field. And even as we advance to higher energies, our hotspots will get better, but we won't be really solving the problem of that distribution. It will always be hot here, and it'll always be cold here. So the method by which we tend to try to homogenize this field is a technique called field in field. And if you have a program called Easy Fluence, which is provided through Varian now, that process can be made automatic. So I'm going to slide to our next image, which is showing you the result of the Easy Fluence and of the field in field that was performed for this patient. So we started off treating the entire ipsilateral breast, doing a nice job of sparing all of our deep and contralateral tissues, but with too much hotspot inside of the field. After our field in field, we have lost a little bit of coverage. You can see that the isodose lines have slipped slightly off of the chest wall, but the 95% line is still very tight. And all of those hotspots above 110 have been eliminated, and the volume of 105 has been made much smaller. Previously, the volume of 105 was almost the entire ipsilateral breast. Now we just have some non-contiguous bubbles that remain in the patient, which is a lot more to our liking. My next slide, in case you're unfamiliar with this concept of field in field, I'm just kind of demonstrating what that is and what that looks like. What's happening is the MLCs are coming in and modulating on this field, and they're going to paint out that hotspot and create a distribution that's more even from the perspective of the field. So let's see if my movie can play, and you'll see that while the beam is turned on, is my movie playing? Let's see. While the beam is turned on, my MLCs are advancing and marching across this field, and they do that more on the anterior side than those deeper tissues. So what the effect is, the deeper tissues are treated for more of this field, and the more anterior portions of the anatomy are treated a little bit less. There's more blocking that happens, such that you create that really nice homogeneous dose effect. This can be done manually by hand, but we are currently using the Easy Fluence tool, which our clinic has really appreciated. One question might become, we're talking about treating using this tangential arrangement, but a lot of centers and for a lot of treatment disease sites, we use IMRT and we use VMAT. And VMAT is great. It is so good at promoting conformity of high doses of sparing of meeting clinical objectives for so many disease sites. But specifically for breast, it's not always the best solution. And let's look at why. IMRT solutions and VMAT together, they really work best when they have a lot of entry angles. For IMRT, we used to do 5 to 9 beams would create that nice conformal dose that we really like. And for VMAT, similarly, it works best when you give it about 180 degrees of freedom. So a typical VMAT plan might arc about 180 degrees, maybe 200 degrees on this ipsilateral side, as compared to the tangents, which only have 2 entry points. We have our medial tangent and our lateral tangent. For when we're talking about breast planning, whoops, let's go back one. Remember, the goal is to isolate the ipsilateral breast and spare the contralateral breast. So you can see a lot of our metrics are designed to meet that goal. We have almost no dose expected of the contralateral breast, the contralateral lung. The thyroid should be pretty well out of the field. And while it's not listed here, Kate did mention about the lower anterior descending artery, the left anterior descending artery. which we also have high ambition to spare. So I'm going to show you again, just as a reminder, what a two-field approach using tangents might look like. I'll pause it here, and you can see that all of the dose is kept very close to the ipsilateral anatomy. Our high doses, our low doses are all following that plane of that medial field border that we designed previously. As compared to a VMAT solution, which does have some favorable dosimetric properties, but one thing you'll note is how much more that low dose is spilling across the deeper and tissues and the contralateral tissues. Here, the contralateral breast or chest wall is receiving much more dose than on this side. You can see that much of the dose is pushing down into the heart, even into the esophagus, the spinal cord. So why would we ever use a VMAT approach? One thing that you can do with VMAT that you can't do so well with 3D is to bend these isodose lines, specifically the higher isodose lines. This was a patient for whom we really needed to spare the LAD, which I have turned on here. This is a cardiac substructure that we do want to spare, and the doctor was not willing to compromise too deeply on our coverage. So if you can kind of imagine the plane of our tangents, which we would have used to treat this patient, we would have been treating straight through that LAD. But using this solution, our isodose lines are bending off of it. So while VMAT is usually not our go-to approach, it can have a role in the management of breast tissue. We use it on a very small population of patients, but it has been used before. I wanted to mention that for left-sided breast treatment, the heart tends to be a little more involved in our field. The apex of the heart tends to veer towards the patient's left side. So when we're designing those fields, it can be tricky. It can be tricky to design a field which treats the ipsilateral breast and spares all of that contralateral anatomy. A really useful tool is to ask the patient to take a deep breath in during the simulation so that we put a little more space between the breast tissue and the underlying anatomy of the heart. I'm going to play my movie again here, and we're going to see the difference between an inspiration breath hold, that's that second image, versus the original free breathing. And hopefully you're seeing that there's a little more space presented there. My line is kind of imagining what the line of my tangents might look like if I was to treat on this inspiration breath hold scan. And I've got about 1.4 centimeters of space between where the heart is and where the medial border would be. If I reimagine how these fields might look on the free breathing scan, you can see that the distance between the field border, where the field border might be, in the heart is a lot lower. I've lost about a centimeter of space between these two scans. So we do, as often as possible, we prefer to treat using an inspiration breath hold technique for left-sided breast treatment. I'm going to move on really quick and talk about a few different methods for doing the breast boost. A lot of these patients will come to us following a surgery. They've had a lumpectomy, and there'll be a lumpectomy scar that we want to deliver a bit more dose to. So I have three methods here that we have used in our clinic. We're going to start talking with electrons, because that is sort of the standard of care. For so many years, I feel like all of these breast treatments and the breast boosts were performed with electrons, and it is a very attractive approach. Remember, we're boosting a surgical scar, and you can usually see that scar right on the patient's anatomy. So it's very easy to target both on the CT scan, but also when you're in the room with the patient. It's very easy to make sure that the field is wrapped right around that scar. And as compared to photons, which we've been discussing so far, electrons are a modality which is characterized by not penetrating as deeply. Photons will penetrate all the way through the patient, but the electrons will stop. At least the higher doses will stop earlier than those than a comparative photon plan will. So electrons work great. Very easy to target, and the high dose can be made very conformal around the tissue that you're looking to boost. The downside with the electrons is that because it is an en face modality, we really want this field to come in and interact as flatly with the field as possible, usually only with one beam. We don't have a lot of control over the low dose spill in the same way that we might with photons. So you can see that for this patient, We actually did introduce a decent amount of low dose spill down towards the ipsilateral lung, down towards the heart. And these are relatively low doses, so it may not be a problem. But there are other solutions out there. So for electron patients, we're really looking for shallow targets where they're not too deep in tissue. And ideally, they're targets that we can target without having to push dose into the underlying anatomy. For other positions of the boost volume, if we have decent space, we can switch over to a photon arrangement. This target that I'm showing here would be a lot harder to treat with electrons because the electrons, as I mentioned before, they don't penetrate as deeply. And in order to create a dose distribution which punches down far enough to treat this target, we would have to have a really enormous hotspots kind of upfield of the beam. Thankfully, this patient had really favorable anatomy such that we were able to design fields which targeted the lesion without really implicating even the ipsilateral lung or the heart at all. So if you have a target which is far from the heart and the lung, consider using photons, and you can be as simple as just placing 2 fields on there, lightly modulated with a wedge, and you'll have a very nice dose distribution. We call this a wedge pair because we have a pair of fields that each are using wedges to push the dose into the directions that make the most sense for our anatomy here. The last arrangement I'm going to show you is becoming more and more popular in our clinic, and we call it a hybrid arc. Again, we're treating using photons, and in this case, unlike the previous case, we don't have that favorable anatomy. Our target is right up against the ipsilateral lung, which we would like to spare. So we're trying to find a solution which, unlike the electron, pushes deep down into the ipsilateral anatomy with the electrons, but we're also trying to keep it tight and conformal. So in this case, we've compromised a bit. We are using photons and we are putting dose into a larger volume of the ipsilateral breast, but we're promoting conformity of those high doses and conformity of that low dose by using an arc. So this is a hybrid arc where we're using 2 tangents, very similar probably to the tangents that we treated the primary breast volume with, paired with a small arc which has very low weighting and which just promotes the conformity of the high dose around this volume without introducing a lot of exit dose to the rest of the patient. We find the solution is easy to treat, it's comfortable for the patients and for the therapists, and it hits a lot of the dosimetric characteristics that we're looking for. So these 3 methods can be used for treating breast boosts, and some of them will even be useful later in our discussion of treating accelerated partial breast. I'm going to jump straight into 3-field breast. And this is where things get a little more complicated, but we're going to walk through it hopefully slowly. So for 3-field breast, as we describe it, we're treating not only the ipsilateral breast, but we're now also treating the involved supraclavicular nodes on the patient's involved side. There are many ways to do this. Previously, I advised that we place our isocenter there at the level of the nipple, where the divergence would be relatively even from the superior and inferior directions. But now that we have to treat this other tissue, which we can't do using the tangents alone, if our tangent was just made large enough in order to treat all of this, we would be treating too much. We would be treating through the humeral head and a lot of tissues that are just not involved. So the best way to treat the supraclavicular space is with a relatively en-face photon field, as we're going to see. So what do? If we have our isocenter here, the only way to create this flat match line, which is what we're after, remember, we really don't want to have cold spots where these fields aren't meeting each other. We really don't want to have hot spots where the fields kind of overlap into each other. We want this match line to be flat. If we use 2 isocenters to create a flat match line using clever kicks of our collimator and our couch, it's going to take longer to treat. We're introducing complexity, which is harder for the therapists and the patient to accommodate on a daily basis, but it also lengthens the treatment time and gives us more opportunity for little errors throughout the course of treatment. So there's a simpler solution. As compared to the original idea of putting the isocenter at the plane of the nipple, we're instead going to find one isocenter that works for all of our fields. So we're looking for one localization technique and one setup to treat both the superclav and the pair of tangents, which are going to target the breast tissue inferior to that. So we call this monoisocentric technique, and this is our recommendation where feasible for our patients. We're going to talk about how to find that isocenter. How do you find an isocenter that works for all three of these? And the good news is that you can follow a lot of those same rules. It gets a little more complicated in that we need to review all of the fields together. And we'll look at that in a moment. But the first thing I want to show you is this is what the two-field isocenter looked like before. This is that same image that I previously demonstrated. Whoops. As compared to what it looks like for our three-field. So before, we had our isocenter at the plane of the nipple. We had our collimator turned to follow the angle of the chest wall so that we had as minimal MLC blocking as possible. And everything else, we're gonna try to do the same techniques. We're gonna have our superior border right at sort of that first intercostal space, right above the palpable breast tissue. We're still gonna have flash. Inferior border doesn't change. But what is different over here is that our isocenter is now at the very top of this field. And we're doing a technique called a half beam block. Whereas before, the two jaws were open symmetrically around central axis. Now my central axis has been brought to the very top of the field, and it's only one jaw, which is shaped around the entire rest of this field, which means there's double the divergence on the inferior side as compared to this original plane. But this is also an area where the divergence matters a little less. The highest priority is to make sure that we have that flat match line superiorly. So in order to keep that match line flat, we also need to not introduce this angle that we previously introduced following the chest wall. So one thing you're noticing is that my collimator is 0. I'm no longer following that angle of divergence. My isocenter is much deeper relative to what I demonstrated before. And I do have a lot more MLC blocking in here, which does introduce a little bit more leakage and scattered to the patient, but we judge it to be a small price to pay for the efficiency and care of these patients. Otherwise, we're still following that same medial border. We're still doing our flash, and our superior and inferior borders are similar. It can be really hard to find an isocenter that looks good just looking at the tangents alone. So it's really important that when we're developing our fields, we look at all of the fields together. So let's talk briefly about some of our tenets for treating the supraclavicular field. Remember, it's going to be the same isocenter. So these isocenter arrangement guidelines that I've given you are the same that I presented on the previous slide. Some of these are easier to see when looking at the supraclavicular field. So as an example, if I'm trying to place the isocenter just inferior to the clavicular head, I can see the clavicle very easy on this field. It's a lot harder for me to demonstrate where the clavicle is and where in the superior inferior direction this iso should be until I've evaluated the supraclav field. So again, we're treating with a single en-face field pointed and targeting at the supraclavicular and some of the axillary nodes where appropriate, but we want to shield those deep tissues. So one thing I'll have you note is that this field is offset and turned 15 to 20 degrees. 15 is what we most commonly do in the opposite direction that we're treating. So I'm treating the patient's right side here, and I have my gantry coming in slightly oblique to the left side. And what this does for us is it allows us to target the ipsilateral anatomy, but to put the divergence going away from the cord, the thyroid, the trachea, the esophagus, all of this midline anatomy that is not involved with the patient's disease. Perhaps you can imagine if this field were pointing straight up and down, that divergence would be moving towards the cord, and we don't want that because these are high doses. And this is a pretty limited technique, treating with just this one field. So here I can see my superior inferior direction. I've placed it just beneath the clavicular head. The first intercostal space is easier to see on the CT scan. Perhaps we'll look at that in a moment. The anterior posterior dimension, I really need to see the tangents to know exactly how far in this dimension to move it. Left to right, we tend to land about 2 to 3 centimeters medial of the medial aspect of the humeral head. And for our field borders, about 5 cm superior of the suprasternal notch is relatively typical. For this patient, it was closer to 6 centimeters. We were also more conservative. Right now, I have this written as the midpoint of the suprasternal notch again, and we are definitely on the ipsilateral side of that. But our doctor confirmed for us that we're treating all of the tissue that we needed to here. My lateral field border was brought just to the lateral side of the humeral head, but we're introducing this block to make sure that the humeral head itself is not being targeted by this field. And the inferior border, we've done a lot of work, remember, to make sure that that match line is maintained and works for all 3 of these fields. So there won't be any collimation here. And we're going to be using that same technique I mentioned a moment ago, a half beam block, where the Y1 jaw is closed down to 0 to maintain that flat match line that we are after for these patients. This is approximately how the field should look on a skin rendering. And it's really important that we do review the skin rendering when we're designing these fields. So on my next image here, these are the medial tangent, the medial tangent and the supraclav viewed together. This is that same isocenter that is working in conjunction with both of these plans in order to create the dose distribution that we want and following all of the tenets that I've talked about before. So here is our tangent. Here's our supraclav, the single isocenter. And when we put this all together and calculate our dose, I'm going to show you a kind of a typical dose distribution for 3-field breast. And this is after we have added our field and field and created that homogeneity. So I didn't mention this before. Oh goodness, these movies. Let's see if it goes. I didn't mention this before, but typically we have the patient's head turned also to the contralateral side. Perhaps you can tell that our patient here has her head kind of tilted away from the angle that we're treating, and that is by design. And that kind of allows us to move this that middle anatomy away. And in conjunction with that 15-degree oblique field, you can see that we are targeting the supraclav nodes, but we're missing and we're sparing the trachea, esophagus, cord, and all of those deep tissues, including the thyroid. So this is our dose distribution going from the supraclav field, perhaps with some light field and field added to promote more homogeneity. Note that the humeral head is not in the field. We have blocked it on the lateral side. And then as we go down to the area of the tangents, it will look very much as it did before with the 2-field plan, where we're isolating the ipsilateral breast from all of the rest of the underlying anatomy and the contralateral anatomy. And together we've created a singular dose solution that works to treat that entire side of the affected patient. Here I still have those. This is the same constraints that I had demonstrated previously for the 2-field, and it is what we are typically aiming for. We're still trying to isolate the ipsilateral from the contralateral, so we still don't expect much dose to any of those volumes wherever we can. Moving on, this is a bit related to the breast boost techniques we talked about before. Kate mentioned this previously too, that for patients with very small, relatively small volumes, we are targeting the entire breast, which was the motive that we've been chasing for all of these slides so far. Here, we're only treating a smaller portion of the breast. So this is accelerated partial breast irradiation. It's accelerated because it's a high daily dose and it's hypofractionated. Because it's a high daily dose, we worry about the patient experiencing toxicity, particularly to the skin. Historically, a lot of these patients are treated twice a day, and the skin will start breaking down if it receives too much dose too quickly. So one of the goals of accelerated partial breast irradiation is to make the isocenters as tight around the volume, to make the isodose lines as tight around the volume as we can make them, particularly the higher isodose lines, the ones that are closer to 100, 90% and above. Your best friend for achieving that objective, if you're trying to control the upper isodose lines and make them tight around your volume, is to do non-coplanar fields. And this is what we did for many years. It's a very attractive approach again. So on our first slide here, I'm demonstrating a non-coplanar arrangement of fields where I have one sort of pathway for the medial field to come in, as we're seeing here, but I've separated this into 2 different fields where the couch has been turned. And what this means is that that entrance dose is being spread through the patient's more superior anatomy and the more inferior anatomy. And anytime you kind of allow that additional spread of entrance dose in the sup and int directions, your isodose lines are going to become tighter because you're just introducing one more way for the dose to kind of wrap around and become tight on the axial slices. So this is a great technique. Let's move on. This is just that same picture made bigger to kind of show you how the superior and inferior beam angles have been separated out. And this is a little movie I just put on. I just wanted to make sure everyone understood and was aware of how we're achieving this effect. I'm going to grab it, and you can see that what's actually happening, if you pay attention down here, is the couch is moving. In order to separate the superior from the inferior, I'm actually moving the couch, which does create that favorable dose distribution that we discussed, but it does make it a little more complicated to treat, because now we would have to go into the room and make sure that anytime something is moving, we worry about collision issues. We want to make sure that everything is happening as safely as possible. So we do like this approach quite a bit, but it has become more favorable in our department over the years to go for that same technique we discussed for breast boost planning, where we're now discussing the hybrid arc again. The value of the hybrid arc is that it does not involve any couch motion. So you just set the patient up one time. The couch does not need to move from that point forward. But how do we deal with this need for the high dose to be conformal? Well, we introduced, kind of similar to VMAT, we actually introduced more angles of freedom. We're actually pairing these two tangents with an arc, which treats in between the two tangents. And by doing this, we've spread the dose entrance out over a lot more of the patient's anatomy, which helps spare the skin and make sure that there's not only one or two beam portals where all of that dose is aggregating. It's now spread out, but it's also creating that conformity that you could not get out of just two fields alone. Here we have these two fields matched to this arc, which is delivering dose and kind of creating that nice shape around our target. Importantly, as with the boost plans, we don't want there to be a lot of like a bath of dose going to the rest of the patient. So you may remember when we discussed VMAT planning for breast, the downside was that we were implicating a lot of the contralateral and deep anatomy. For that reason, this is an arc, and you run into that same concern. We want to make sure that this arc is treated with a lower weight. We kind of walk a balancing line of making sure that we promote conformity by using this arc, but we don't push too hard because otherwise we're going to have more dose spill to the rest of the patient. So I think I have one more picture just kind of showing that field geometry. Let's see. Just making sure everyone's aware that we are treating through an arc, which kind of begins on the patient's medial anterior side and sweeps all the way down to the lateral side. I think this is my last slide, potentially, and this is just a brief discussion about prone breast, which a lot of clinics do use for patients who have really pendulous breast anatomy or for very unfavorable locations of the surgical cavity that we need to make sure is in our field. It can be advantageous to treat using this prone setup. So here I've got another little movie where you can see the patient is positioned sort of face down on the table. And this allows the breast tissue to come forward and usually allows for us to target that ipsilateral breast and spare all of those deep tissues. If the cavity is very lateral, this can be very hard to do if the patient is laying flat on their back. The downside to this is that it is less comfortable for the patient. It's harder to reproduce generally. And as I've made my window really bright here, we also introduces clearance issues because now the patient is much further away from the tabletop. In order to create this effect, we're using a prone tabletop, which allows the anatomy to fall forward. But that means that the patient is very high up compared to how they would otherwise be treated. So it's a little harder. You have to work with your teams and your clinics to make sure you have good guidance about how to treat these patients without introducing collision issues or any kind of safety problems. Good guidance would be that the isocenter should be as anterior as possible. And in this case, anterior means closer to the table because they're face down, and as medial as possible. You want to put the isocenter as close to the middle of the table as possible. So we might use some asymmetric geometry for this plan in order to kind of create this effect without having problems with clearance. Reproducibility is something that I think comes a lot with training the therapists. I think if the therapists get into a good habit of treating these patients, they'll know how to coach them better, and you'll find that your service improves over time the longer people have been doing it. That was a very high-level, quick discussion. We could talk about this for ages, but that is where I'm going to end today and invite any questions. And once again, thank Kate for her excellent lead up into my discussion.
Thank you, Jonathan. That was excellent review. Awesome. Any questions from the audience?
Hello, everyone. I am Dr. Radiation Oncologist from Kyiv. Thank you a lot for very interesting explanation this topic. It's very important for us, for our practical job. I have some questions about in what practical case you use additional boost of radiotherapy on the scare that you irradiate chest wall. Because unfortunately in our clinic frequently do mastectomy, and we must treat the patient with mastectomy, chest wall, and lymph nodes with clavicular lymph nodes, and sometimes when we have the advanced case, we have questions, do additional boost of the scare or not, and in what case you recommend this?
Yes, thank you for that question. So the question about boosting the scar after mastectomy.
Yeah.
Yes. So, you know, there's not a lot of data on the addition of a scar boost after mastectomy. There are some perhaps retrospective data. I think here at Stanford, I know my colleague, Dr. Marquez, and I will often consider it in a situation, for example, if they have a lot of disease after completion of neoadjuvant chemotherapy or a skin involvement. So we might consider it in that case. I don't routinely do it, but a lot of it depends on the individual situation.
Mm-hmm.
And what's the typical dose you use?
Usually I do 10 gray in 4 to 5 fractions.
And the way we typically treat the scar is with electrons, using typically 9 MeV electrons with 1 cm of bolus, and irradiate around 3 cm around the scar.
Right, I was going to say with margin. Mm-hmm.
With margin, yeah.
Unfortunately, we have not possibility use the electron therapy, and we use photon therapy, and we understood that risk of the organ of risk in this treatment, and sometimes it's a difficult question for us. And second question is about the bolus. In what case we recommended use bolus on this situation?
Yes, another area of controversy, or at least discussion, because again, it's not clear in the literature suggesting that maybe we don't need to use bolus as much as we thought in the past. I know we kind of individualize it because depending on the thickness of the flap, whether there's reconstruction or not, just really trying to make sure that tissue gets adequate dosing. And so we'll individualize it depending on, you know, what dose we're able to achieve and whether the bolus then can help or not.
Thank you a lot for your answer. Good day for you. Thank you.
Thank you. Any other questions?
Thank you for your presentation. I have a question about thermoplastic masks. Are you using it for breast?
Sorry, I didn't hear the question about what?
Thermoplastic masks.
Thermoplastic masks.
Oh, No, we haven't been using that here. That's an interesting question for sure. I can imagine that it could be helpful, particularly with more pendulous breasts, but we haven't used that here.
Or if you do IMRT, that's more of a necessity to immobilize the breast. But here we use 3D for most of our patients.
Okay, and thank you. And second question, can you estimate percentage of VMAT or IMRT cases for breast? Or you use only 3D conform?
What's
You're
the
asking about-
percentage of cases we use IMRT?
Yeah, so I would say here it's only probably about 5 to 10% of cases, and there's a couple of reasons. Number one is Jonathan pointed out, obviously, the concern about low dose to normal structures. The other thing, at least in the United States, it's variable as to whether insurance will cover it or not. So sometimes you have to have more of a complicated case involving the internal mammary nodes that then the insurance will cover it. Otherwise, I think even for billing purposes, it's restricted. That's not necessarily the case across all United States, because I know, for example, in New York, they use it a little bit more routinely, but they have different insurance carriers. So I would say that we're influenced both by, you know, the treatment plan, but also unfortunately by the payment.
And Kate, this provocative question, let's say if insurance really covers it, do you think you would switch to IMRT technique or still keep 3D?
Well, Dr. Marquez and I have talked about this a lot, and you know, the plans look better for sure, although I think we tend to see a lot of young patients. As I mentioned, in the United States overall, median age is 61, but we see a lot of women in their 30s and 40s, and I think we're kind of influenced, or at least paying close attention to some of that low dose scatter in young patients, which we know in their lifetime might lead to a higher risk of complications. So I think we would individualize it for sure, but I think we're influenced a lot by the demographics of our patient population.
Okay, thank you. And last question about source of dose volume limits table. Jonathan, you show.
Those are the sort of the in-house constraints that we're using. So this is a document that we drafted up, but
I think it's from NSABP B39, right? Yeah, that's from a clinical trial. Our CTP now.
Probably. Perhaps we can provide that in the chat or as like an email follow-up later, where those constraints came from.
Yes, thanks. It's really good. Thank you. Thank you so much.
Yeah.
Thank you very much, dear colleagues, for your presentations. It's very important to us, to our practical work. I'm a radiation oncologist from the Kyiv, and actually I would like to continue the topic about the treatment planning. And actually, I agree with Jonathan that sometimes 3D is the better than IMRT and VMAT. It's depend on the anatomy and our goals of the treatment. For example, it's could be for partial breast irradiation as good 3D as VMAT. And in our clinic, we routinely do 3 plans for every patient. It's 3D, IMRT, and VMAT. And after that, we evaluate DVH and those constraints, and we choose the preferable technique for the current patient. Sometimes we did the hybrid treatment when for the breast we use 3D, and for the boost, for example, MRT or VMAT. So it's good as well. So thank you for emphasizing such possibility. So not in every case the advanced planning is good for the breast. And my question about the reconstruction. We have the very good breast surgeon. He do the oncoplastic reconstructions with the autologous tissues, and mostly it's the rotate flaps and flaps with perforation. So we need to preserve the vessel that ensure the blood supply for these flaps. And what is the technique that preferable in this situation? For example, we use the hyperfractionation, 1.8 grade perfection to the 50.4 the total dose. What maybe is your recommendation in that case? Thank you.
Well, I guess it also depends on the vessels. At least here, they anastomose to the internal memory vessels. And so I guess the question comes into play whether I need to treat the internal memory nodes or not. If I don't need to, meaning a lateral lesion or such, then I would probably lean away from that in a patient who had an anastomosis to the point you're making about minimizing damage to that anastomosis. Otherwise, I actually think your approach is a good one, and also moving towards more hypofractionated regimens where we're using a lower total dose may end up being less toxicity and damage, late tissue damage. Interestingly, I haven't actually, we tend to do a lot more implant-based reconstruction here, so I haven't run into that problem.
Okay, thank you. And maybe what the recommendation with implants, it's the conventional fractionation or another types of fractionation, maybe you?
Yeah, so currently I've been doing conventional fractionation, although we did participate in the trials that's looking at hypofractionation after mastectomy and reconstruction. So I think those results will be presented soon and we may move in that direction.
And the last question, what is your attitude to the hyperfractionation to the lymph node regions radiation as recommended in the last NCCN guidelines? Have you used it or?
No, very similar to the situation of the chest wall with reconstruction. We participated in the trials, and I think that there are emerging data supporting the use of hyperfractionation for the regional nodes, and we'll get more data in the near future, and likely we'll be moving in that direction as well.
Thank you very much.
If I may, I have a question about extreme hyperfractionation. Fast forward. So we have treated just a few patients with this regimen. What are your thoughts?
Yes, so I've not taken it, I've not used it as readily as they have in the UK. I have been using it on a few patients. I think importantly, we have to follow these patients after the treatment is over because they get through treatment in 5 days, but sometimes the toxicity will occur the week or 2 weeks following. And so I think that's something that we need to pay close attention to as well. So I've kind of been exploring that, but really with a heightened awareness to what's happening after they finish the treatment.
Any more questions from the audience? Thank you so much. We'll conclude this session. Thank you, Kate and Jonathan. This was excellent. Thank you for teaching us.
Thank you, Natalia.
And we'll resume on Friday. See you Friday. Bye-bye.